Most health systems are leaking money in social care, not because that services do not work, but because the system is fragmented. Kaiser Permanente was facing the exact challenge under its advancing and innovating Medicaid transformation initiative in California. Kaiser fixed that problem without cutting services, but by redesigning how accountability works. Welcome to HealtheNomics. I am Dr. Ayoub Ashraf. I work in healthcare strategy and execution. In this series, we examine real success stories from leading health systems that how executives are solving complex challenges around quality, equity, access, and cost. I believe keeping patients healthy and out of the hospitals is not only possible, it is actually profitable. Kaiser, under its CalAIM initiative, was suddenly responsible for delivering enhanced care coordination and community support services to some of the most complex populations in healthcare. People experiencing homelessness, serious mental illness, substance use disorders, and repeated hospitalizations. But here was the problem. To deliver those services, Kaiser had to work with more than 300 community based organizations, each with different workflows, documentation standards, response times, and accountability structures. That level of fragmentation is expensive. It creates delays, lost referrals, poor visibility, and ultimately preventable utilization. What Kaiser did next is what makes this case so powerful. Instead of trying to manage 300 contracts, Kaiser redesigned the operating model. They created what is called a network lead entity model. Rather than contracting with hundreds of providers, Kaiser contracted with just three regional network lead entities. These NLEs became accountable hubs while Kaiser stayed focused on strategy, funding, quality, and oversight. And the NLEs handled coordination, subcontracting, performance tracking, and frontline execution. That one decision changed everything. Referrals stopped getting lost, documentation became standardized, closed loop tracking became possible, and leadership finally had visibility into what was actually happening after a referral was made. Each NLE operated as a regional command center, running intake hubs, routing referrals, tracking outcomes, and reporting performances using standardized dashboards. So instead of chaos, Kaiser had structure. Instead of hundreds of data feeds, they had only three. And instead of fragmented accountability, they had clear ownership. There was another smart decision embedded in the model. Kaiser did not centralize community health workers. They allowed NLEs to hire locally embedded CHWs, the people with lived experiences who are culturally aligned and have trust within the communities they serve. That one design choice improved engagement dramatically. There were fewer no shows, better follow throughs, stronger relationships, and most importantly, better outcomes at lower cost. Why we can call it a financial strategy instead of just a social intervention? Because it prevents avoidable emergency visits, it prevents unnecessary admissions, it prevents delays caused by broken handoffs, and it also prevents administrative overhead that explodes when systems try to manage hundreds of contracts independently. This model did not require Kaiser to micromanage operations. They stayed focused on performance. They held quarterly reviews. They tracked days to engagement, completion rates, repeat utilization, and CHW touchpoints. And above all, they allowed flexibility as long as outcomes were delivered. So, what is the real takeaway for healthcare leaders? This case shows that social care at scale does not fail because it is ineffective. It fails because it is poorly organized. Kaiser's network lead entity model turned social care into an operationally disciplined and functionally sustainable system. For organizations which are struggling with SDOH, care coordination, or community partnerships, this lesson is clear. You do not need more contracts, you need fewer and smarter ones. And when accountability is centralized, workflows are standardized, and community trust is preserved, outcomes improve, and costs come down. This is not about adding complexity, it is about removing friction. And that is how systems protect both their mission and their margin. This case was presented at the American College of Healthcare Executives Congress 2025 by Kenisha Campbell and Vidya Iyengar from Kaiser. I also want to share that I don't have any financial, administrative, or advisory relationship with Kaiser or the individuals mentioned. Thank you so much for your time.